Healthcare, opioids, overtreatment, neglect, and different insurance models.
Presented
by Hallie Taylor,
Ashlyn Openshaw.
Nate Fierro.
Parker Neild.
American healthcare is often unnecessarily expensive and reduced in quality due to excessive opioid prescribing, overtreatment, and overmedication, and disregard for alternatives to patented medications, neglect in assisted living facilities, and the inability to find out the right usage of health insurance models.
In the past decade, and especially since COVID-19, home healthcare has been on the rise. There are many benefits to it, as there is much better pricing and more personalized care. Jonathan Gooch, an advocate of home healthcare, on a TED-Ed video discusses how also insurance companies are moving towards home healthcare, ultimately proving its beneficial value. Assisted living facilities have benefits, but there are a lot of unnecessary disadvantages that come with it. At Pine Creek Rehabilitation and Nursing, located in Salt Lake City, Utah, it was found that nurses neglected to notify hospitals when their patient's blood pressure was dropping. This raises a lot of danger to the patient and their safety.
America's healthcare industry has been greatly affected by changes in new national inventions. America's healthcare has become more of a control switch for money and power rather than the health and our well-being. The industry has learned to recreate pills, changing nearly nothing but raising the price. They are wired to give us long-term pills to depend on rather than to give us immediate long-term solutions with short-term treatment, with the knowledge that they can make more money off of us if we have to depend on medication for the rest of our lives.
There are easy ways to reduce healthcare costs that Americans can begin using now. Using the generic medication over the name brand medication can save hundreds of dollars with generally the same benefits. Many colleges and universities have health institutes, and often these offer much more cost-friendly care. Sometimes these institutions even have free care. These are good to use for yearly checkups or typical hospital visits.
Factor 2. Opioid prescriptions. Christopher Perotto was a remarkable student and talented baseball player. At the age of 20, he was prescribed opioids for back pain following his involvement in a minor car crash. It took Christopher only 5 days to become addicted to the drug. As his tolerance grew, his intake increased from 1 pill a day to 25 pills a day. Within 2 years of his first opioid prescription, Christopher overdosed and passed away. This is the danger of opioids. Johns Hopkins University describes opioids as a class of drugs that derive from or mimic natural substances found in the opium poppy plant. They are typically prescribed to relieve pain. Some examples of prescription opioids include hydrocodone, codeine, methadone, morphine, oxycodone, and fentanyl. These drugs are extremely addictive, and the CDC even claims as many as 1 in 4 patients receiving long-term opioid therapy in a primary care setting struggles with opioid addiction. Additionally, Johns Hopkins University claims about 75% of people in the U.S. who became addicted to street opioids such as heroin during the 2000s report that they started out taking prescription opioid drugs. This means that many abusers of the legal street opioids began using them after developing an addiction from legal prescriptions. Opioid addictions are extremely dangerous, as overdosing can stop a person's breathing, resulting in death. A report published by the CDC mentions how the number of drug overdose deaths increased by nearly 30% from 2019 to 2020 and has quintupled since 1999. What's more, nearly 75% of the 91,799 drug overdose deaths in 2020 involved an opioid. Despite their addictive nature, opioids are prescribed frequently in American healthcare. A report mentioned by the CDC suggests that more than 191 million opioid prescriptions were dispensed to American patients in 2017. Excessive opioid prescribing is especially prevalent in the state of Utah. A report published by the Utah Department of Health in November 2021 estimates that 74,628 patients experiencing acute, disabling low back pain were prescribed opioids during 2019. A follow-up report published in 2022 suggests this number was 77,635 in 2020 and 75,991 in 2021. The Utah Department of Health flags these prescriptions as wasteful, meaning most of them likely weren't necessary. According to the CDC, non-opioid therapies are at least as effective as opioids for many common types of acute pain. The CDC recommends prescribers maximize non-pharmacologic and non-opioid pharmacologic therapies for acute, subacute, and chronic pain as appropriate for the specific condition and patient. They also advise prescribers to only consider opioid therapy if expected benefits of pain and function are anticipated to outweigh risks to the patient. With this information in mind, it is easy to see how Utah clinicians are overprescribing opioids to patients experiencing acute, disabling low back pain, putting them in danger of addiction, which can be fatal. Another group of patients potentially being overprescribed opioids in Utah is women experiencing pregnancy. According to a study that was published in 2019 and led by Marcella C. Smid, an assistant professor at the University of Utah in the Division of Maternal Fetal Medicine, 42% of pregnant women insured by Medicaid are prescribed opioids in Utah, the highest rate of any state in the nation. The study also found that drug-induced death was the leading cause of pregnancy-associated death within the state of Utah between 2005 and 2014. 77% of these deaths were opioid-related, and 60% were attributed specifically to prescription opioids. Overall, 323 people died from a prescription opioid drug overdose, 156 people die from a heroin overdose, and 88 people die from a synthetic opioid overdose every year in the state of Utah, according to the Utah Department of Health. Why do clinicians prescribe so many opioids? Ronald Hirsch, a physician who has been practicing internal medicine for over 20 years, has offered insight into this issue. Hirsch admits, "We overprescribe opioids just as we overprescribe antibiotics. But it is generally well-meaning. We don't want our patients to experience pain." According to Hirsch, most physicians don't prescribe opioids for malicious reasons. Instead, they prescribe opioids because they recognize their ability to provide powerful, immediate relief from pain. The CDC does, however, acknowledge that non-opioid therapies are often as effective as opioid therapies for many kinds of acute pain. There are instances when pain is severe enough to warrant the use of opioids, but the CDC recommends physicians prescribe the lowest possible effective dosage. Ronald Hirsch mentions how we prescribe 30 or 60 pills when 5 or 20 would have been adequate. He claims physicians do this because they are used to prescribing in multiples of 30. Clinicians may prescribe opioids in excessive quantities simply out of instinct or because they don't understand what quantity of opioids is adequate for a prescription. It is also worth noting that the CDC recommends clinicians to always discuss realistic benefits and known risks of opioid therapy with patients before prescribing it. Physicians should also regularly reevaluate benefits and risks of continued opioid therapy with patients. Of course, there are some physicians who prescribe opioid therapies for their own benefit. Corrupt pharmaceutical corporations like Insys Therapeutics illegally incentivize clinicians into prescribing ever-increasing dosages of their patented opioid therapies. Prescribers may be bribed with money in the form of cash or donations, vacations to exotic locations, and other forms of compensation.
Factor 3. Health insurance models. The Bismarck model, found in Germany, Japan, Belgium, Switzerland, and to a degree in Latin America, is where private insurance plans are financed by both the employer and employees. This insurance plan covers everybody and they don't make a profit, which makes them basically charities. Tight regulation of medical services and fees keeps the cost under control. The Beveridge model, originated in Great Britain, is what most Americans have in mind when they talk about socialized medicine. In this model, there are no medical bills and healthcare is a public service, like the fire department or public library. Hospitals and clinics are owned by the government, but there are still private doctors. In the national health insurance model, treatment providers are private but funded through a government program that citizens pay into with a premium or tax. The national or provincial insurance plan collects monthly premiums and pays medical bills. Since there's no need for marketing, no expensive underwriting offices to deny claims, and no profit, these universal insurance programs tend to be cheaper and much simpler administratively. The final insurance model is the out-of-pocket model. Only approximately 40 of the 200 countries have any established healthcare payment systems. The majority of countries in the world are too poor or too disorganized to provide mass medical care. The brutal rule for these countries is that the rich get healthcare while the poor get sick and eventually die. Possible solutions. The Heritage Foundation recommends switching into a consumer-first ideology of healthcare, as opposed to the government deciding which healthcare providers get our tax dollars, the people do. Another possible solution is stated by Reed, that the United States could be providing quality healthcare and distributing it fairly and equitably. The only way the U.S. could possibly figure out if there was a model better suited for us is to try new things. However, an entire change to the healthcare and insurance system in the United States could be disastrous. So if there's anything we can do, it's to start slowly and figure out what works and what doesn't work. Then we can continue to make progress in finding a solution to better, cheaper, and fairer healthcare.
Final solutions. Solutions to unnecessary procedures and costs. Try to avoid name brand medication, as lesser known medicines can save patients a lot of money, which are still giving many of the same benefits. Also, research and ask questions about the procedures that are being done in hospitals to ensure that these procedures are necessary rather than just being an added cost. And finally, promote home care over hospital health care, as it is much more beneficial to the patient and is about 1/3 of hospital care costs.
So, how do we address America's opioid crisis? Well, the first step is reducing the number of opioid prescriptions being dispensed. We can do this by utilizing the Improving Wisely model, a framework created by doctors at the Johns Hopkins University School of Medicine, such as Marty Makary, to reduce the rate of all kinds of unnecessary procedures. The first step in the Improving Wisely model is identifying a medical procedure that is overpracticed. In our case, we would need to identify which operations and diagnoses are commonly being unnecessarily treated with prescription opioids, such as acute disabling low back pain and pregnancy pain. We must then obtain national data outlining how many opioids are being prescribed and how often they are being prescribed that treat each of the operations and diagnoses we identify. Once data is collected, appropriateness metrics can be created detailing how often a certain operation or diagnosis warrants opioid therapy, and how many opioids should be prescribed to treat said operation or diagnosis. These appropriateness metrics should be based on scientific research and the national data collected previously. According to Marty Makary, a surgeon at Johns Hopkins University and a key developer of the Improving Wisely model, metrics will need to be revised each year based on the latest scientific research, society guidelines, and an evolving consensus among practicing specialists. After we create appropriateness metrics, we can use data to identify outliers. Clinicians prescribing more opioids than what has been established as appropriate for any given operation or diagnosis. Once outliers have been identified, we can notify them about where they stand and encourage improvement. The goal is not to chastise clinicians who are overprescribing opioids, or to prevent patients who can genuinely benefit from opioid prescriptions from accessing them, but instead to create a culture of accountability and improve prescribing habits. Another way we can reduce opioid prescriptions is by spreading awareness about their risks. By informing patients of the dangers of opioids, we can enable them to make smarter decisions regarding their health in collaboration with their clinicians. One campaign already pursuing this cause is Choosing Wisely, an initiative that helps patients choose care that is both supported by evidence and truly necessary. Reducing opioid prescriptions is only the first step. We can't just stop feeding the fire, we need to also put out the fire. Many individuals already suffer from opioid addiction, and both addictions and deaths will persist after prescriptions have been reduced. The next step in addressing America's opioid crisis is improving access to harm reduction services. Harm reduction is both a strategy and a philosophy that allows addicts to use drugs in a way that is maximally safe for them. These kinds of services provide addicts with things like sterile syringes, safe injection sites, and evidence-based medications like naloxone that can reverse a drug overdose. By improving access to harm reduction services, overdose rates will drop and those who become addicted to opioids will be safer. It is worth mentioning that harm reduction services do not reward individuals for using drugs. As mentioned earlier, about 75% of people in the US who became addicted to street opioids such as heroin during the 2000s report that they started out taking prescription opioid drugs. Many abusers of street opioids aren't necessarily at fault for their addiction. In most cases, their addiction developed after being instructed by licensed clinicians to take legal prescription opioids. These people need help, not reprimanding. Studies have shown that, in stark contrast to compulsory detention, these approaches are globally effective, represent good value for money, and are often cost-saving. Harm reduction services may be able to save thousands of lives and thousands of dollars. Improving access to harm reduction services can be achieved by lobbying state legislatures for increased funding and support. The final step in addressing America's opioid crisis is improving access to long-term rehabilitative services. These services provide individuals with evidence-based treatments for opioid use disorder, like methadone, buprenorphine, naltrexone, and behavioral therapies. It is important that victims of opioid use disorder have multiple entry points into treatment within their community. Improving access to rehabilitative services can also be achieved by lobbying state legislatures for increased funding and support. Incorporating both harm reduction services and rehabilitative services into the prison system would be especially beneficial. Many abusers of illegal street opioids attribute their addiction to prescription opioids, and it is crucial that individuals incarcerated for using street opioids have access to treatment. This will enable them to overcome their addiction and safely re-enter society without risk of relapse. The integration of these services into the prison system deserves legislative attention and should not be overlooked.
Solutions to health insurance. Begin testing different models of health insurance and implementing different models into healthcare. See which ones work and which ones don't. This is the testing stage. This means trying out the consumer-first ideology as well as using ideas from the four models. We do this by starting in our state and being pioneers in our own health insurance. This needs to be a legislative act and can only be done through the Utah legislation, not through protesting and grassroots organizations.